Let's begin with pneumothorax. So now coming to the definition. So what is the definition of pneumothorax? So presence of air in the pleural cavity is known as pneumothorax. Now first of all, what is the pleural cavity, right? So pleural cavity is the space between the parietal and the visceral pleura. Now normally around 5 to 10 ml of fluid is present in the pleural cavity. If it is beyond that amount, it is usually uh, so it is known as pleural effusion, right? Now, if there is normally there is no air present in the pleural cavity. If there is air is present, then it is known as pneumothorax, right? Now, pneumothorax can be localized when it is due to a previous disease. There is adhesion of the parietal and the visceral pleura, or it can be generalized when there are no adhesions. So now imagine that a patient has some kind of infection and he has developed loculated pleural effusion, or he has developed adhesions of the parietal and visceral pleura. So in between those two adhesions, there will be trapped air, which can cause localized pneumothorax. So again, another important cause of localized pneumothorax, you can say it can be rupture of a subpleural bleb. So the pneumothorax will be present in the localized area, but around it adhesions should be present, right? Then only it will be localized in that space. If adhesions are not present, the air will be present throughout the cavity. Now it is generalized if there are no adhesions. Now I want all of you to imagine a person coming with breathlessness, right, and chest pain. Let's imagine like right-sided, okay, right-sided breathlessness or right-sided chest pain. I'm saying right-sided because all the cardiac causes will not come to your mind. That's why I said right-sided. So right-sided chest pain with breathlessness, okay. Saturation is 50-60. And it is not improving with oxygen. Even if you're giving oxygen, the saturation is improving to 85-90, but the patient is still breathless, and you can see all the accessory muscles are working of respiration. So this is the clinical scenario. So when I'll be explaining the further points based on this clinical scenario. Now coming to the etiology, so it can be either spontaneous or traumatic. So spontaneous can be open, closed or tension pneumothorax. Traumatic can be iatrogenic and non-iatrogenic. Now traumatic will be iatrogenic means what? You're doing any kind of procedure. One very common procedure which can cause pneumothorax is your pleural tapping. Once you do pleural tapping, if the if you don't use a three-way properly and if you let air seep in, right, that is the reason of using a three-way in case of pleural tapping. If you don't use it, you will cause iatrogenic pneumothorax. Then any kind of thoracoscopy or thoracocentesis, any kind of these procedures. Even while putting an ICD for pleural effusion, many times air can seep in rare cases, it can cause pneumothorax. But the treatment of pneumothorax itself is ICD, so no further treatment is required in such cases. Okay. Now coming to spontaneous pneumothorax, okay, in case of traumatic non-iatrogenic means what? Rib fracture, flail chest, or any blunt trauma to the chest, right? It can cause pneumothorax, especially open injuries. Now coming to spontaneous means it does not have any kind of trauma involved or any kind of procedure is not involved. It can be open, closed and tension, okay, which I'll be explaining subsequently. So now as explained previously, iatrogenic, it is transthoracic needle aspiration, subclavian vessel puncture, thoracocentesis, pleural biopsy and sometimes high pressure like barotrauma like mechanical ventilation. It can also cause iatrogenic pneumothorax. Now coming to the non-iatrogenic procedures which can cause pneumothorax are penetrating trauma and blunt trauma. So these two are the things which can especially blunt trauma and penetrating both, which are non-iatrogenic causes of traumatic pneumothorax. Now coming to primary spontaneous pneumothorax. Primary spontaneous pneumothorax occurs in absence of any disease. Okay, so it occurs in the individual without trauma, and it is common it is a very important clue rather when you are solving questions. Age group is 20 to 40 years. It occurs without trauma, and the patient will not have any underlying respiratory disease. Usually risk factors are tall persons or patient has pleural blebs. So now imagine this is the pleura, this is the parietal and visceral pleura, okay, and here is the lung bleb, pleural bleb. Now this bleb or this bleb will rupture and it will lead to pneumothorax. Air will escape and go into the pleural cavity. Majority of these persons have recurrence, and both lungs are affected in equal frequency. And one more important point is usually the apical areas are affected in case of primary spontaneous pneumothorax. Now coming to secondary spontaneous pneumothorax. Now in secondary spontaneous pneumothorax, usually the patient has an underlying respiratory disorder. The most common causes, as we routinely see in medicine OPDs as well as in case of emergencies also, is COPD, that is chronic obstructive pulmonary disease, which contains both chronic bronchitis and emphysema, right? And another important, in India, anything comes, you always one of the causes is tuberculosis. So cavitatory active pulmonary tuberculosis occurs due to rupture of the emphysematous bullae and subpleural TV focus, cystic fibrosis, yes, and pneumocystis carinii pneumonia. So these are some of the causes of secondary spontaneous pneumothorax. So the major differentiation point between primary spontaneous pneumothorax and secondary spontaneous pneumothorax is that primary spontaneous pneumothorax is the pneumothorax in which the overlying lung is absolutely normal. There is no overlying lung disorder. But in secondary spontaneous pneumothorax, the lungs, there is a underlying lung disorder, especially COPD or tubercular focus. Other causes which they might mention will be cystic fibrosis and pneumocystis carinii pneumonia. Now again, I would like to make you imagine the patient which I told previously. That is a 50-year or middle-aged man coming with right-sided chest pain, breathlessness, with saturation around 55-60, with accessory muscles of respiration working, and the the respiration or the blood saturation is not improving with oxygen. Okay. Now coming to that, if you imagine that man, and I would like to go ahead with the clinical features so that you will be able to recollect and remember better. Okay. This topic is very simple. If you understand this, you need not revise it also. You are going to get the questions correct if you are able to understand the concepts well. Now coming to clinical features, that is sudden onset of unilateral chest pain. Again, as I said, right-sided chest pain, breathlessness. And the severity of the breathlessness depend on extent of lung collapse and severity of the underlying lung disease. Now imagine that a patient has tuberculosis or chronic bronchitis, or he has cystic fibrosis, right? So there is inherent he has breathlessness because of his underlying disease. Apart from that, he'll have breathlessness due to pneumothorax. So the quantity, the extent of pneumothorax will depend on the extent of breathlessness will depend on the extent of the pneumothorax plus the underlying disease. Now coming to tension pneumothorax, patient will have labored breathing, cyanosis, tachycardia, and diffuse diaphoresis. Now imagine that this is the pleural cavity, okay, and this is the lung, okay. Yes. So now in case of tension pneumothorax, air will only go into the pleural cavity, but it cannot go into the lung back. So it will compress the lung. The pressure will be on the lung, this direction. Okay, so the pressure will be on the lung. Now the lung will compress. Now what is the normal pleural pressure? Pleural pressure is usually always negative. Now when air is present in the pleural cavity and it starts compressing the lung, the pressure in the pleural cavity will be positive. Okay, now this positive pressure, what will happen is, it will, one important factor, it will compromise the venous return, right? Now in case of, now if you know your basics correct, in case of during inspiration, a negative suction force is generated because inspiratory pressure is, the pressure in the pleural cavity during inspiration is negative. The venous return increases in case of during inspiration, right? That's why that is the basis of cardiac maneuvers, right, which we do, right-sided murmurs and left-sided murmurs. Okay, that's a different topic altogether, but that is the basics of it. So during respiration or during inspiration especially, the negative pressure will, there is negative pressure in the pleural cavity increases, so the venous return increases. Now when the there is positive pressure which is compressing the lung, so first of all the venous return or will decrease in case of pneumothorax or in case of any causes of increase in the pressure in the pleural cavity. The venous return will decrease, so the cardiac output will decrease. So the cardiac output will decrease, which will further increase the breathlessness. So there is distress, so there is tachycardia because cardiac output is low, right? There is profuse diaphoresis to maintain the cardiac output. The heart rate will, there will be an attempt, or there will be an increase in the sympathetic nervous system to maintain the cardiac output. And cyanosis, because oxygen is not there, right? Because of impaired oxygenation, the lung is compromised and hence there will be cyanosis. I think I am clear with the points I've covered. Let's move ahead. Now coming to the physical signs. Now imagine the same patient. Now the patient will be cyanosed. The patient will be tachypneic. Okay. The peripheral pulses may be feeble, again because of the reduced cardiac output. Hypotension may be present. Now coming to the respiratory system. Now imagine the basics first. Okay. Now coming to respiratory system. Now imagine there is pleural cavity. Okay, there is air in the pleural cavity which is pushing the trachea towards the opposite side. Now imagine there is air in the pleural cavity. So the patient is breathless. Okay. Now the accessory muscles will be working. Trachea will be shifted to the opposite side. Now this is the basic concept. If there is a lung collapse, it will pull towards, or fibrosis, the trachea will be pulled towards the same side. But if there is a mass, or if there is massive pleural effusion, or if there is pneumothorax, the mediastinum or the trachea, in short, the trachea will be shifted to the opposite side. So keeping these basic concepts in mind, let's move ahead. Now coming to the inspection and palpation of the patient, the accessory muscles of respiration will be working. Trachea and apex impulse will be shifted to the opposite side. There will be fullness of chest, obviously, because of the air in the pleural cavity. There will be diminished chest expansion on the affected side and diminished chest movements on the affected side. Okay, so the movements will be reduced. Okay, expansion will be reduced. So obviously because of there is fullness of chest on one side. So imagine that patient which we have thought about in the first initially. So there will be right-sided increase in the spino-scapular distance. There will be markedly diminished vocal fremitus on the affected side. There will be subcutaneous emphysema might be present. Percussion, there will be hyper-resonant note over the thorax. Auscultation, there will be marked diminished or absent breath sounds on the affected side. And there will be absent adventitious sounds. So like there will be no creps or no V's or heard on the affected side. There will be diminished breath sounds because air is there, chest expansion is reduced. Okay. Percussion, there will be hyper resonant note. dull note, then it is a pleural effusion. So that's how you will differentiate. Okay. A subcutaneous emphysema might be present. So now, again, imagine that patient, he has come to you in case of emergency. Okay. So the clinical you're suspecting, ideally in such a situation, we don't even wait for, if the patient is collapsing, we don't even wait for the x-ray. We just poke the needle in, wide bore needle in second intercostal space. But yeah, the initial will be in an emergency setting, obviously just x-ray. So now standard erect x-ray in inspiration, sharp defined edge of the deflated lung will be seen. There will be complete translucency or absence on bronchoalveolar markings. There will be mediastinal shift to the opposite side. CT scan is useful for diagnosis of difficult cases. Usually we don't have time for CT if the patient, if there is an emergency in case of tension pneumothorax. So now this is a very important diagrammatic representation which will help you understand. So this is a closed pneumothorax. So closed pneumothorax means what? That air cannot go in nor go out. Air has gone in and the inlet has sealed. So air can neither go in nor go out. And this will resolve spontaneously on its own. Open pneumothorax means what? That air can go in and out. So both directions. Air can move in and out. So the pneumothorax air will also go out. So it will not usually compress the lung. It can, but it doesn't usually. In case of tension pneumothorax, it's an emergency, as I told you. In this situation, air can only go in, but it can't go out of the pleural cavity. And ultimately, the pressure will build up inside the pleural cavity and it will compress the underlying lung and cause tracheal. As you can see, one second. As you can see, it will cause tracheal or the mediastinal shift. See, tracheal shift will be there and it will compress the underlying lung. Okay. So now coming to the treatment of tension pneumothorax, it is an acute medical emergency. Emergency treatment is obviously insertion of large bore needle into the subpleural space, right? So this is the pleura, right? So you will insert a needle over here into the subpleural space so that air is drained out in case of emergency situation, right? Diagnosis is usually confirmed when large amount of air escapes through the needle. Now, if you work in a very clinic, if you're doing internship or if you've worked in a very busy setup, and if you've seen actual traumatic pneumothorax cases, if you puncture, you will see one gush sound. So that itself is confirmatory. Yes, so you will see that more frequently, right? In other scenarios, it is very difficult to get actual classical case of tension pneumothorax. Then after that, another way to confirm is you put the needle, you fill the syringe with half syringe with saline, and you put it over the needle. You will see bubbles of air gushing through the needle. So that is one more bedside confirmatory test. Okay. Then the needle should be left in place till thoracostomy is inserted. Thoracostomy tube, that is ICD, is inserted. So coming to recurrent spontaneous pneumothorax, it is common with emphysematous bullae. Obviously, I told you previously, as subpleural blebs, they rupture and they'll cause emphysematous. They'll cause pneumothorax. Usually occurs on the same side. So I have emphysema of localized emphysema, suppose on the left side of the lung. I'll always have pneumothorax on the left side. I'll never develop on the right side. So treatment is pleurodiosis. Now pleurodiosis means what? This is visceral and parietal pleura. In this pleura, I'll put such a substance which will irritate, which will act as a chemical irritant, and which will cause an inflammatory reaction and ultimately lead to fibrosis of the parietal and visceral pleura, and which will ultimately lead to adhesion of the parietal and visceral pleura. So there will be no space only left for the air to accumulate in this. So there is obliteration of the pleural space. Intrapleural installation of the irritant, like, now what substances are used? That is tetracycline hydrochloride, talc, many times streptokinase is also used. Now recommended after a second pneumothorax. So whenever there is patient has a second pneumothorax or recurrent pneumothorax, always the treatment is fluoridesis. You have to do the procedure, okay, because recurrent pneumothorax is dangerous. Pneumothorax itself is dangerous. It is life-threatening. Now, catamenial pneumothorax. Catamenial pneumothorax means what? Anything catamenial pneumothorax is pneumothorax during menstruation. Okay. Now, anything catamenial usually means at the time of menses. So, catamenial epilepsy. Patient has seizure during menses. So, this will give to a clue to one of the, if you know the concept, you will be able to answer the question well. Now, when will patient have catamenial pneumothorax? So, it is usually rare. It is usually occurs in females, obviously, about 25 to 30 years. Repeated attacks of pneumothorax on the right side in association with menstruation. It occurs 2 days before or after the onset of menstruation. Hemoptysis may develop. Mostly commonly seen with endometriosis of the thorax. Treatment is ovulation suppressing drugs, surgical exploration, and fluoridesis. Now in this, patient has usually, what is endometriosis? Endometriosis is endometrium is present outside the uterus. So in rare cases, it can be present in the pleural cavity. So such cases may lead to catamenial pneumothorax. Classically, along with it, patient may present with hemoptysis, and the treatment is ovulation suppression, like you give oxypills basically. Now, what is clicking pneumothorax? Small cells pneumothorax get localized in front of the pericardium. It produces alteration of the heart sounds. So the sounds become loud and resonant. That is clicking. So this is known as clicking pneumothorax. These are very important one-liner MCQs. Now coming to complications of pneumothorax. If you understand a very simple infection, okay. Now because of infection, it can lead to pneumothorax, right? Because of the procedure or the treatment, right? Then there is hydropneumothorax, and there is mediastinal or subcutaneous emphysema. So these 3-4 are the complications of pneumothorax. So I would like to cover even hydropneumothorax, right, under this topic. So usually all the clinical findings are usually the same, except for the fact that percussion note will be hyper resonant over the air containing part, and it will be stony dull over the lower fluid containing part. Coin test is positive over the upper air containing part. Succussion splash can be elicited on the affected site. So this succussion splash is you put one coin on one side and step on the opposite side and shake the patient, and you can auscultate the succussion splash. So this is just for theoretical purpose. So it can come as an MCQ. That's why I've mentioned about it. So this is a picture of actual how ICD needs to be done. There is you insert an ICD in case of pneumothorax from the patient. From there, it should be connected to an underwater seal, and from there it should be connected to an underwater, which should be connected to wall suction. So this should be the ideal procedure, but this is usually we do not follow. We don't have, many of the ICU setups don't have this provision for these set of 3 bottles. So what we usually they do is this tip only they insert in the water. This should be immersed in the water. So there will be bubbling of the water. So that's how you will come to know that air is escaping out. And one more thing, you should always monitor that you will understand that the ICD is functional, right? There will be oscillation of the air fluid column inside this one second. So this is, imagine the fluid level is up till here, okay, in this. Now this level will oscillate up and down with respiration like this. It will keep on oscillating. That's how you will come to know that it is exactly in the pleural space or it has come out. How will you come to know that it is in the pleural cavity or it has come out? Right? So that is the bedside way to confirm. So this is, you should know the representation of this so that you'll be able to answer the picture-based questions, image-based questions, I'm sorry.